Welcome to today's learning series webinar. So pleased that you can join us once again for this conversation on alternatives to opioids, really discussing the current best practices on opioid prescribing from the CDC and VA guidelines. Today's webinar has been approved for one AMA and ANCC credit, and we have no disclosures for faculty or planners for this learning activity. Today's webinar is brought to you by the Partnership for a Drug for New Jersey and is being held in collaboration with NJ Cares and the New Jersey Office of the Attorney General, as well as the Opioid Education Foundation of America and LICAD. And we thank them for their partnership, support, and collaboration on today's learning activity and throughout this year-long series. And I welcome all of our new attendees who don't normally join this learning series from throughout the country, as well as from Long Island specifically, who are members of or affiliated with LICAD. I'm pleased to welcome today's expert panelists. Both of them are from the Organization for Physicians for Responsible Opioid Prescribing, Dr. Andrew Kolodny and Dr. Jane Ballantyne. Thank you both for being with us today. Appreciate your sharing your expertise with us on both the new CDC guidelines and the VA guidelines. And so without any further ado, Dr. Kolodny, I'll turn it over to you.
Thank you, Angela. Let's get started. So what I'd like to begin doing is to give you a brief update on the opioid crisis. And I'm going to go through some slides. I'll explain where we are right now. And in particular, I'm going to focus on why, despite the fact that we've experienced a soaring increase in overdose deaths involving illicitly synthesized fentanyl, why more cautious prescribing is still necessary. So what you have in front of you is the most recently available data on drug overdose deaths, in particular opioid overdose deaths in the United States. And the black line is showing us total opioid overdoses, and then you'll see the lines below that for the specific opioids that are involved. And you'll see the brown line, which represents fentanyl, is by far the opioid most likely to be found in a decedent's toxicology report, followed by prescription opioids, which are in orange, and then heroin, which is in blue. And you may notice that the heroin line is sort of sloping downward at a pretty noticeable rate. What we're seeing, particularly in the eastern half of the United States, is almost a disappearance of heroin as the opioid used on the black market, almost completely replaced by fentanyl. Whereas early on, it was really fentanyl being added to the heroin supply. Now it really is a matter of fentanyl replacing the heroin supply, which of course has led to a sharp increase in mortality because fentanyl is a much more dangerous opioid than heroin. There is something somewhat positive here on this slide that you have to look closely to see. Which is that solid black line at the top, which sort of parallels the solid brown line for fentanyl. Do you see how it's been coming down? For the past 6-7 months, we're seeing overdose deaths coming down a tiny bit. And the reason that's newsworthy is because the deaths haven't been going up, which has really been the trend for almost 25 years. We seem to always see the opioid overdose deaths rising. In 2018, we had a brief plateau. So, the fact that fewer Americans are dying of opioid overdoses, that the number is going down, maybe that's something that could be a hopeful sign. Maybe we're rounding the corner. Obviously, if this trend does continue, it will mean we are rounding the corner, which again is very positive. Something to be hopeful for. Nothing to celebrate when we are still experiencing record high levels of opioid overdose deaths. As you may know, drug overdose deaths in the 2022 year, total drug overdose deaths exceeded 100,000, most of which were opioid-related overdoses, most of which were fentanyl. This slide is showing you again, sort of a longer timeline and the breakdown of different drugs that have been found in overdose deaths. And what you'll see here on this slide is that from around 1999 until around 2015, that there's a blue line, a light blue line that sort of tops this, and that's prescription opioid overdose deaths, which were by far the drug most likely to be involved in an overdose death in the United States. And then you'll see, if you look down, the dark blue line starts to go up around 2012 until around 2015, it's going up. And then you see the gray line that just with that soaring increase, and that's fentanyl. And very often you'll see this, this slide described as three waves of the opioid crisis: the prescription opioid wave, followed by a heroin wave, followed by a fentanyl wave. I personally don't find the wave terminology all that helpful. In fact, I think it's a little bit misleading. Often that narrative is used to suggest that there was a crackdown on the pills, so that the prescription opioid wave, in the context of the pills drying up, so-called drug abusers then switched to heroin, and then they switched to fentanyl. And it sort of implies that we have this homogenous group of drug abusers in the United States, which is a term I don't think we should use, but that's the narrative, who sort of switch from one drug to another based on availability. And that narrative is not really accurate. It is true that the vast majority of individuals who began using heroin after 1996 were first addicted to prescription opioids, but the switching happened much earlier. And we really have an important epidemiology to opioid addiction in the United States, meaning differences among different groups of people, Americans who are opioid addicted, not this homogenous group sort of moving from one drug to another in lockstep. We also have very important geographic differences, which I'll show you. As I mentioned, the switching from prescription opioids to heroin began much earlier. It didn't happen in 2013, when heroin deaths began to go up, or 2015, when fentanyl deaths began to go up. Among young white Americans, the switching from prescription opioids to heroin starts happening at the beginning of the prescription opioid crisis. It really begins happening in the late 90s. You see on this graph, these two graphs that begin in 2003, already a sharp rise in addiction to heroin measured by treatment seeking. If you look at the graph on the right, that's African Americans. The graph on the left is whites. The colors of the lines are referring to age groupings. And if you just really focus in on the red line to start, you'll see that among Americans 20 to 34 years old, certainly if you look first on the right at Blacks 20 to 34, you really don't see much rising use in heroin. In fact, you see a decline. And among young Blacks in the United States, declining initiation of heroin use has been a trend in place for about 40, 50 years. Similar also with crack cocaine. Young African Americans in inner city communities began to stay away from crack cocaine. You still find heroin users and crack cocaine users in inner city communities, but they tend to be an aging, shrinking cohort. And we'll come back to that in a minute. If you look at young whites in the United States, 20 to 34 years old, you see a soaring increase in heroin, and an increase that, again, didn't start in 2013 or 14, supposedly when the pills dried up. It began much earlier. And these were young white folks who became addicted to prescription opioids, either from medical use of prescription opioids, or they became addicted through non-medical use, or sometimes a combination of both. A young person who, for example, may have had a brief exposure to opioids, wisdom teeth, minor sports injury. They didn't get addicted from that brief exposure, but they basically got their first taste of the drug from a doc or a dentist. And they're not afraid of the drug because they took it and it didn't hurt them. They may have liked the effect. And at some point after that medical exposure, there's a period of non-medical use that then results in addiction. Now, for these young folks who became addicted to prescription opioids, regardless of how they became addicted, once addicted, they need to maintain their opioid supply. And even in the early 2000s, doctors were generally uncomfortable giving healthy-looking 25-year-olds a large quantity of opioids on a monthly basis for a diagnosis of chronic pain. Unless the doctor was a pill mill or essentially a drug dealer, they generally didn't like doing that. So young folks who became addicted to prescription opioids wound up on the black market to maintain their supply. And the pills are very expensive on the black market. And so if that young person was in a region of the country where heroin was available, they would switch to it because heroin would produce the same effect as oxycodone, but was just much less expensive. And what we've seen happen steadily, not suddenly in 2014 or 2015, when supposedly there was a crackdown on the pills, but steadily from the beginning of the prescription opioid crisis, we start seeing heroin move into more regions of the country to meet demand for it by this growing number of young people who became addicted to prescription opioids. Now, I'd like you to take a look at the green line on this graph, 45 and up. Now, if you look, for example, at African Americans 45 and up, the green line, you'll see for age groupings for Blacks with heroin, that's the age group with the 45 and up with the most heroin use. And again, that's an aging group of folks who became addicted to heroin in the 1970s and 80s, and their addiction began with heroin. If you look at whites 45 and up, you really don't see rising use of heroin. Unfortunately, that does not mean that middle-aged white Americans have been spared from the opioid crisis. In fact, middle-aged white Americans have been one of the hardest hit groups, and I'll show you that data in a moment. So why no rising use of heroin? Well, for middle-aged and older white Americans who become addicted to prescription opioids, and more often their addiction began through medical use, this is a group that generally has not had a hard time getting lots of pills on a monthly basis from doctors. And even when a geriatrician or a primary care doc might get nervous because the patient is coming in early, showing signs of addiction, very often the patient will explain that their, the behavior that looked like addiction was driven by worsening of pain. Often these patients get referred to pain management, and then it's very hit or miss. They can land on a pain management doc like Dr. Ballantyne, who will try and work with that patient and get their opioid dose down, maybe try to get them off of opioids, or they could wind up on a pain management doc who has no qualms about going even higher on the opioid dose. Something many people don't recognize is before fentanyl emerged, we actually saw far more opioid overdose deaths in the older group of Americans who were able to get pills more easily from doctors than we were actually seeing in the younger group that was switching to heroin. Of course, all of this begins to change after 2012, but up until around 2012, you'll see that the tallest bar on this graph is that light blue bar. That's the opioid pain reliever bar showing you deaths in the age group 45 to 54, which is where we're seeing most of the deaths, more of the deaths. If you look just at heroin, the dark blue, you'll see the age group with the most heroin deaths was that 25 to 34 group. What we start to see is with the emergence of fentanyl and a much more dangerous opioid prescription, a much more dangerous black market opioid supply, you start to see deaths in this younger group catch up. And this graph ends in 2015. If it continued, you'd see that younger group now far exceeds the deaths that we were seeing in that middle-aged group that was dying from prescription opioids. When fentanyl emerged, there was a very clear geographic distribution to the fentanyl problem. It was really initially affecting the eastern half of the United States. During COVID, we saw fentanyl really spread to the rest of the country, but initially it really was the eastern half. And among the geographic areas that were hardest hit with fentanyl were inner city communities. In fact, the area hardest hit by fentanyl in 2016 was inner city Washington, D.C., where you have this older group of African Americans who are really longtime heroin users. These are individuals who they're far more likely to be male than female. They're in their 50s and up. Their addiction began with heroin. And these are mostly men who managed to beat the odds for 40 or 50 years despite their heroin addiction. But when fentanyl emerged and that heroin supply became so dangerous, they began dying at a very high rate. And you'll see that here, when you look at older Americans who've been dying of opioid overdoses, that dark blue line that really separates from the rest of the pack beginning around 2014, that's this older group of African Americans who are longtime heroin users. Roughly speaking, we have three groups of opioid addicted Americans, and I've just now told you about all three. The first group is that younger group that switched to heroin after getting addicted to prescription opioids. The second group is that middle-aged and older group that never really needed to switch to heroin and had mostly been dying from prescription opioid overdoses, and where we saw the bulk of the deaths before fentanyl emerged. And the third group is this older group that's disproportionately non-white, older. Their addiction began before 1995, and it began with heroin. Where fentanyl has been taking its heaviest toll is on group number 1 and on group number 3. These are headlines that have appeared in newspapers and online coverage of the opioid crisis. And I think it's really important to frame the problem, because we all use the term opioid crisis, but what are we really talking about when we use that term? We know that the opioid industry, the way that they typically liked to frame the problem was as an abuse problem, meaning that the reason we've got all of these problems is that there's a subset of drug abusers in America who want to take these drugs for fun and they're accidentally killing themselves. That's the way Purdue Pharma wanted us all to think about it. And of course, if you frame it that way, then maybe the answer is you make pills harder to abuse, so-called abuse deterrent formulations, but certainly you wouldn't want less prescribing, which was their main message. You also sometimes have very well-intended public health officials who frame the problem as, it's an overdose death crisis, which I think is also the incorrect way to frame it, because you're sort of missing what was driving the bulk of these deaths. And we know the vast majority of these deaths are occurring in people with a preventable and treatable condition, opioid use disorder. The correct way to really frame the crisis is as an epidemic of opioid use disorder, meaning that the reason that the United States has experienced record high levels of opioid-related overdose deaths, the reason we saw heroin and fentanyl flood into communities across the country, the reason we've experienced a soaring increase in infants born opioid-dependent, outbreaks of injection-related infectious diseases, an impact on our workforce. The driver behind all of these health and social problems that we're referring to when we use the term opioid crisis has been an increase in the prevalence, the number of Americans suffering from opioid use disorder. Today in the United States, roughly, we have about 4 to 5% of the adult US population suffering from opioid use disorder. This is an older slide from the CDC. The green line is showing you the rise in sales for prescription opioids. The red line is showing you deaths involving prescription opioids, and the blue line is showing you addiction, opioid use disorder, measured through treatment seeking. And the CDC's point in putting out this slide was really to communicate the message that what's really been driving the crisis has been that green line, that as the medical community started to prescribe opioids very aggressively, as the prescribing went up, it led to parallel increases in addiction and overdose deaths. And when the CDC really started to push this message, they experienced quite a bit of criticism from opioid industry funded pain organizations and key opinion leaders who really attacked the CDC, arguing that the CDC had it wrong, that the prescribing shouldn't come down. All we need to do is make the pills harder to crush or teach doctors to monitor their patients more closely. But that green line should continue to go up, and hey, CDC, knock it off, because you're going to make the problem of untreated pain in America worse, as if opioids are an answer to the problem of untreated pain. Drug makers weren't simply paying front groups to push that message. They were also spending quite a bit of money to block states and the federal government from introducing interventions that would have resulted in more cautious prescribing. Over a 10-year period, $880 million were spent on lobbying efforts. The opioid lobby outspent the gun lobby by 8 times. And so, for example, 8 times more than groups like the NRA were spending trying to block restrictions on guns in the United States. What caused that green line to go up? Why did we see this soaring increase in prescribing that led to our epidemic of opioid addiction? Well, there's a really good clue on this slide. It's really the year that the prescribing takes off for oxycodone, and you'll see that the prescribing goes up in the year 1996. The blue line is oxycodone consumption in the United States. The red line is oxycodone consumption in Europe, and you can see it's not even close. Fortunately for the United States, that blue line has continued to come down. I'll show you the more current data in a moment. Unfortunately for Europe, that red line has been going up pretty significantly in many countries. And along with the increase in opioid use in Sweden, Switzerland, Norway, Netherlands, England, France, Israel, those nations are also experiencing parallel increases in opioid-related harms. But here you see the year that the prescribing took off, and that's actually the year that a multifaceted campaign was launched to convince the medical community that we were allowing patients to suffer needlessly because of overblown fear of addiction. And it wasn't just Purdue Pharma doing this when it introduced OxyContin. Other opioid manufacturers participated in this campaign. And for a nice overview of aspects of this campaign, particularly Purdue Pharma's role, I would highly recommend the Dope Sick series on Hulu, which would give you a sense of how all of this played out. Fortunately, we have seen litigation against the opioid industry. I've had the opportunity to participate as an expert witness testifying against the opioid industry in the courtroom, and you've seen some very large settlements, and we're still seeing more of this, and this is resulting in funding for states to address the opioid crisis. I think for advocates, it's important for us to really make sure that the funding does get used to address the opioid crisis, because state legislatures, when this money comes in, have the opportunity to use it to maybe lower taxes or fill potholes. We really do need to make sure that the money gets used the right way. I mentioned that prescribing has been coming down. You see, you get a sense of it on this graph. This is showing you opioid consumption in the United States measured in terms of weight of all the opioids consumed in a morphine milligram equivalent. Sometimes you'll see a similar graph where instead of measuring in weight, they're counting the number of prescriptions written, and it looks like we've had a more significant decline than we really have. Counting prescriptions is not a good way to measure, because you're counting a prescription with a few pills of Vicodin the same way you might count a 30-day supply of very high dosage pills. This really is the better way to measure population level consumption. Something else to note as you look at this is that fentanyl and heroin, they didn't emerge when the pills had dried up in the context of a crackdown. They emerged when we were really at the top of this mountain. So it wasn't the taking away the prescription opioids that caused this crisis. It was the flood of opioids leading to an epidemic of opioid use disorder, which led to demand for heroin and fentanyl. If you look at opioid overdose deaths involving prescription opioids and not involving fentanyl, which is that light gray line at the top line coming down, you'll see as prescribing has trended in a more cautious direction, we are seeing fewer prescription opioid deaths. Here's a sort of a very positive note to begin. I'm going to wrap this up and then introduce Dr. Valentine. But this is sort of a positive sign. This is data from Florida, but we're seeing it from across the country. A couple of years after prescribing starts to trend in a more cautious direction, we begin seeing fewer infants born opioid dependent, fewer infants with neonatal abstinence syndrome, or also called neonatal opioid withdrawal syndrome. This is happening across the country. And what this is telling us is that less women of childbearing age are becoming newly hooked on opioids. Again, a very positive sign that more cautious prescribing is resulting in fewer Americans becoming newly hooked. we still have a long way to go. We're still prescribing too aggressively in the United States, which means that there are still Americans every day becoming newly hooked on opioids. But at least fewer and fewer Americans are becoming newly addicted. And I think a sign of that, good evidence of it, would be neonatal opioid withdrawal syndrome. How do we bring the opioid crisis under control? We have to prevent more Americans from becoming opioid addicted. And this is where the medical community and healthcare organizations can play, and teams can play a really important role, for example, in making sure that we decrease exposure to opioids for patients while they're in hospital beds. Often we don't need to use opioids aggressively in a hospital bed, and we certainly don't need to be sending patients out the door with aggressive opioid prescriptions. NSAIDs, there's some people who can't take an NSAID, a drug like ibuprofen, because they have medical contraindications, but most people can take NSAIDs. They are safer than opioids, and they are as effective as opioids, even for severe pain. And of course, if we want to see deaths coming down in the short run, we have to do a much better job of expanding access to effective treatment for opioid use disorder. There's certainly a role for harm reduction, expanding access to naloxone. There may be a role in inner city communities where you have large numbers of homeless injection drug users. Safe consumption sites might make sense, and certainly an intervention we should be trying and studying. And there's a role for law enforcement, because if you can make black market opioids more expensive and harder to obtain while making treatment easier to get, I believe more people with opioid use disorder will seek treatment, because the quality of life for someone with opioid use disorder is awful. The individuals who are injection drug users of opioids are not choosing alternative lifestyle that they're enjoying. They really are suffering. Every morning they wake up feeling sick and in withdrawal, especially when the dominant opioid in the black market is fentanyl with a very short half-life. So if we could make treatment easier to get, if we could make fentanyl harder to get, more people would seek treatment. In summary, the United States is in the midst of the worst worst addiction epidemic in our history, one of the worst addiction epidemics in world history. To bring that epidemic under control, we have to see that we prevent more Americans from becoming opioid addicted, and that for the millions who are addicted, they have access to effective treatment. I am going to stop here, and I'm going to, and hopefully Dr. Ballantyne can begin to share her screen. I would just like to say a couple of things about Dr. Ballantyne. For those of you who may work in the field of pain medicine, I probably don't need to introduce Dr. Ballantyne. She's well known nationally and internationally. She has edited one of the primary textbooks that's used in the field of pain medicine. Dr. Ballantyne did her training in the UK. She went to medical school at the University of London, did her residency training at the University of Oxford, at Oxford University. And when she came to the United States, she, working in the field of pain, she ran Mass General Hospital's pain program for several years. That's the Harvard pain program, and is now at the University of Seattle, and has been well known for her work promoting more cautious opioid prescribing. I'm currently the president of Physicians for Responsible Opioid Prescribing, but Dr. Ballantyne is the immediate past president. The one other thing I would just like to say about Dr. Ballantyne is that within the pain community, she was really one of the first to say the emperor's got no clothes on. And she did that in an article that appeared in the New England Journal of Medicine in 2003. And it was, I think, the first article in the medical literature critical of using high doses of opioids long-term for chronic pain. And when she published that piece, it was at a time when, certainly in the pain community, it was almost taboo to say anything negative about opioids. And so she got quite a bit of flack from some of her colleagues in the field of pain, and it took a lot of courage on her part. So I'm very happy to introduce Dr. Ballantyne. Jane?
Well, thank you, Andrew. Thank you for that introduction. It's my pleasure to be here. I'm going to, since I am a pain physician, I'm going to focus more on opioid guidelines that have been produced by the CDC and the VA hospitals. And I'd also like to finish by talking a bit about what we have learned from neuroscience that explains why we have such bad experience with chronic opioid treatment for the treatment of pain long term. There were lots of things happening actually, when I first came to the United States, which was the 1990s, I was involved in the top left-hand corner of this. The AHCPR, the government, started writing guidelines for pain management. That was soon followed by a lot of pressure on the Joint Commission, which accredits US hospital organizations to have some means of ensuring pain management or attention to pain as part of its quality assessment. And that was followed 10 years later by the Institute of Medicine producing this book, Relieving Pain in America, in which they identified that there were millions of Americans suffering untreated pain, and that it was costing, as this book says, $635 billion in medical bills, lost productivity, and missed work. So, what we know now, that the effect of the what we call the JACO mandate was to introduce into hospitals the idea of always assessing pain and using pain measurement, or the derived score from pain management, as a vital sign. So what was wrong with this? Well, the problem was it equated existent pain, or the very existence of pain, with untreated pain. So all these mechanisms suggested that if pain existed, it was undertreated, it needed to be treated. Well, we've understood a lot more about pain since the 1990s, and we now look more at what is so-called high-impact pain, and we were able to identify that high-impact pain, which is the pain that really lends itself to aggressive medical treatment, is much lower numbers than the numbers that were suggested by these earlier assessments of the prevalence of pain. So, because of the the effect of these initiatives to identify the problem of pain, or put out to the general community that pain was an enormous problem and costing a lot of money and a lot of unhappiness, opioid prescribing did increase. And Dr. Kolodny has already shown you a lot of the figures. This also shows that between the year 2000 and 2010, prescription opioid prescribing went up enormously, to the point that it was declared by the CDC as an opioid epidemic, and that was an epidemic of prescription opioid overdose deaths and abuse admissions. And so the CDC went to the table and decided it needed to intervene, and what its intervention was to write a guideline. That was the 2016 CDC guideline for prescribing opioids for chronic pain. And this was a huge effort. This was involved an evidence review. There was a big team of investigators who spent 2 years looking at the entire literature, English language literature, peer-reviewed literature. There was also a contextual review. That was another team of people who were looking at things like epidemiological evidence. And there was a panel of experts who came up and wrote this guideline. And it was written specifically for use by general practitioners, not by specialists. And it was written specifically for the treatment of chronic pain. The main message of this guideline was that, first of all, that the evidence review did not support long-term opioid prescribing. What it showed was that the analgesic efficacy of opioids deteriorated over time, and the harm increased over time. So that the recommendation in that guideline was that non-opioid treatments are preferred for chronic pain. That's the language the CDC chose to use to express that the evidence didn't support long-term opiate use. The other things that are important in this guideline, or key findings, was that they suggested using short-acting opioids, especially when initiating opioid treatment, and avoiding the use of long-acting opioids. They also suggested extra precautions when the dose reached 50 morphine milligram equivalents, and avoiding altogether doses over 90 morphine milligram equivalents. And the last important or key recommendation in this 2016 guideline was that 3 to 7 days was usually sufficient for acute pain. So they suggested discontinuing treatment when it's been started for acute pain after 3 to 7 days. The 2016 CDC guideline was successful in that prescribing did come down, and that was clear from some of the figures that Dr. Colon has already shown you. But there were also problems. It had some unintended consequences, and those unintended consequences were really related to a misunderstanding of some of the guidance by physicians themselves, by a failure to understand what opioid dependence means, what people who've become dependent on opioids are struggling with. And also the guidelines were interpreted as rules when they were only intended as guidance, and people were afraid of consequences such as loss of license to prescribe or to practice. Pharmacies began to have their own rules and refused to supply doses above the CDC recommendations or durations above the CDC recommendations. Insurance companies also declined to pay for the medications as guided by the CDC guideline, and local guidelines also had their own guidance and rules, or what was interpreted as rules. So CDC has just published, or in 2022, published a follow-up guideline, went back to the table, re-looked at the evidence, and the CDC themselves recognized that there had been misapplications of their 2016 guidelines. So on this side, I've listed what the CDC themselves felt was misinterpreted about their 2016 guideline. That there was extension to patient populations that were not intended. So it was used for the cancer and palliative care where it was not intended, particularly the dose restriction. That opioid tapers and abrupt discontinuation was happening without collaboration with patients, which was also not intended. That there was too rigid an application of the opioid dosage thresholds, that the applications of the guidelines recommendations for use of medications for chronic pain was stretched too far into the treatment of opioid use disorder. And insurers and pharmacists were also introducing duration limits, and patients were being dismissed and abandoned because doctors were afraid of continuing to prescribe. So in 2022, when the CDC went back to the table and re-looked at the evidence and re-looked at their guidance, what they found was even stronger evidence that supported exactly what had been found before in their main finding, and that was that long-term opioid treatment had what they called, in their language for the 2022 guideline, is diminishing returns. In other words, as you go through with longer duration and higher doses of opioids, the analgesic effect becomes lessened and the harm becomes much greater. And they summarize that in saying that there are diminishing returns at higher than 50 morphine milligram equivalent dosing. Now, this is what you will find within the main document, which is a very long document, but it's clear throughout that very long document that the evidence is even stronger and the dose is even lower, that you reach a point where you get diminishing returns, as they put it. They also found that alternatives to opioids are often more effective, particularly for acute pain, particularly for certain types of acute pain, like inflammatory pain, dental procedures, minor or moderate day case surgery. Often non-steroidals are more effective than opioids. And they also identified a lot of harm from abrupt, rapid tapering, and that had been an unfortunate and unforeseen consequence of the 2016 guideline. So the key differences between the 2016-2022 guidelines, many of the recommendations are exactly the same, but because of everybody's concerns about abrupt discontinuation and the extending of that into pharmacies and insurance and the fear that actual identification of doses in the bullet points of the 2022 guideline, unlike the bullet points of the 2016 guideline, it was felt that the dose limitation should not be firmly stated, and likewise the duration should not be firmly stated. So the main difference between these two guidelines is that in the 2022 guideline, despite the fact that the evidence is even stronger and the dose limitation throughout the body of the text is even lower, that this wouldn't be mentioned in the bullet points of the guideline. And unfortunately, most people only read the bullet points, so that's even doctors and especially the press. The other thing is the guideline focused on two completely new ways. One is, how do you help people who've already become dependent on opioids? Because that was not a focus of the 2016 guideline. And also, there was a huge effort to look at alternative to opioids, and particularly at non-steroidals, which is where they came up with a recommendation that for many procedures, non-steroidals actually have better analgesic efficacy. So the press actually, got the wrong end of the stick, that they thought that because, and they widely after the publication, actually after the publication of the draft of the 2022 guideline, they said that the implication widely in the press was that the CDC had loosened its guidelines. In fact, it hadn't not. All it had done is be careful not to name doses in the bullet points that it published. But when you look at the main document, it's actually the opposite. The dose is lower and the cautions are even greater than they were previously. So let's look at the, so in terms of what this new guideline offered, there are several important points. One is that patients who are already on opioids are a different group, completely different group from people who are not yet on chronic opioids. And the original 2016 guideline was focused on the second group, that is people who are not yet on chronic opioids. So all the guidance about dosing and whether to start or not really applies to a population that are not already on opioids. And part of the problem was that it was applied to people who are already on opioids. And now we see that population is very different from the population that is not already on opioids. So the new guideline makes a strong point of not tapering these dependent patients abruptly, but it also reiterates that it's rarely necessary or advisable to start chronic opioid therapy, that non-opioids are often effective, and that daily doses are over 50 morphine milligram equivalent are rarely helpful. So the VA and Department of Defense also published a clinical practice guideline, and they had three, or you can identify three very strong statements that they made. And their language is actually much stronger than the language of the CDC, even though in summary, their guideline is very similar and their findings are identical. They say we recommend against the initiation of opioid therapy for the management of chronic non-cancer pain. We recommend against long-term opioid therapy, particularly for the younger age groups. And we recommend against long-term opioid therapy, particularly for patients with substance use disorder. So if you, just to summarize what the VA DOD guideline says, I'll start at the bottom. There are differences in some of the scope of these between these two guidelines, but they don't have any contradictory recommendations. Their findings are the same, and their recommendations do not contradict each other. One thing the VA document emphasizes is that there's no evidence to support risk mitigation strategies. So what that means is that early on, when we started encouraging greater use of opioids in the 1990s, it was recommended that you would try and assess what the risk is and stratify your treatment according to risk. Now we know that there's no evidence to support these risk mitigation strategies. In other words, if someone has a risk of a substance use disorder or developing a substance use disorder or already has a substance use disorder, the best approach is to avoid giving them opioids altogether, because if they're on opioids, none of our risk mitigation strategies like measuring urine tox screens or asking people to comply with an agreement or looking at prescription monitoring actually stops this progress into addiction. They also recommend assessing risk for suicide whenever making dose changes, because the problem of people being taken off too rapidly and becoming distressed and sometimes committing suicide. They also emphasize buprenorphine as an alternative to pure mu opioids for the treatment of pain. So, you know, the essence of this guideline is exactly the same, but some of the scope is slightly different, but the message is the same. And that is that they don't recommend initiating opioids for the treatment of chronic pain. I just put this slide in just to show that, you know, the way we think about pain these days is that chronic pain obviously is a very broad classification. Not all chronic pain syndromes are the same, but the ISP has recently categorized chronic pain into chronic primary pain on the left and chronic secondary pain on the right. So chronic secondary pain implies that there's some underlying cause. There may be some treatment that can be aimed at the underlying cause and treat pain as a symptom, whereas chronic primary pain, no underlying or cause or cause in the periphery can be found, and the disease is a primary condition and encompasses all these second level diagnoses like chronic widespread pain, which would be fibromyalgia, complex regional pain syndrome, chronic primary headache, which would be migraine and tension headaches, chronic primary visceral pain, which would be things like irritable bowel syndrome, as opposed to Crohn's, which would be chronic secondary visceral pain, and chronic primary musculoskeletal pain. And the reason that's important is that all these conditions on the left are very common, more common than the conditions on the right, and also they are not responsive to opioids. So we would generally recommend that none of these conditions on the left are treated with opioids. So what else do you do for these patients? And one of the things about the way we look at it now, and a greater understanding of chronic primary pain conditions, is that if you do prescribe opioids, because the opioids commandeer the endogenous opioid system, the alternative treatments don't actually work very well, because a lot of the alternative treatments work through the endogenous opioid system. So this is, just a list of all the alternatives we can use. They're very effective, particularly in people who've never received opioids. I just want to spend the last minute or so on, the neurobiology of opioid dependence and why that matters and why it helps us understand why opioids don't work very well long term. So, if somebody's already on opioids, we recommend not tapering or discontinuing abruptly. The only exceptions would be safety concerns. There are very good guidelines out there published by SAMHSA and HHS, and so they're good guidelines to follow. And we found very useful the use of buprenorphine for these patients who become dependent. So when you take opiates long-term, the brain or the nervous system is going to adapt. And so there are always going to be adaptations to continuous use, and they're going to be manifest clinically as tolerance and dependence. So tolerance, we know, is the need for a higher dose, and dependence is, you'll see, a withdrawal when the drug is taken away. But tolerance and dependence in terms of the underlying adaptations are really the same thing. They're exactly the same adaptations, that with different clinical effects. But the important thing about tolerance is that it's not just a desensitization, which is relatively simple, things like membrane changes, receptor changes. Those are all reversible. But there's another process, an opponent process, which is not reversible. It's persistent and enigmatic, depends on the person, the circumstance, and learning, and it's pervasive. So you think of it as a drug effect is a so-called A process. It's what the drug does initially, that it elicits pleasurable emotional state and pain relief. And a B process is what the brain does in order to oppose, because it's trying to achieve homeostasis, and it's counter-regulatory. It produces drug opposite effects. So just imagine anything the drug does that's good, the brain is going to try and do and produce the opposite or bad effect. And you can see in this figure, if you look at the middle of this figure, that the A and B is separated out just for the sake of the figure, but the top line shows what actually happens. And that is the B effect, what the brain is doing. By the time you've got to panel C, which is several doses or months of treatment, the effect is no longer there, the positive effect no longer there. And the negative effect doesn't recover as quickly as it does in either panel A or panel B, which is after a few doses. So B, that is what the brain is doing in response to the drug, is actually dragging it down and producing an effect that doesn't recover even after the drug is stopped. Dependence is another manifestation of tolerance. It's most obvious during withdrawal, but it also occurs continuously because any emotional change can alter level of tolerance. And so the way the addiction specialists would look at it, at addiction, is a cycle, the second stage of which is this withdrawal stage. And when we look at pain patients, they may not go through the first stage or even come out of the second stage because they don't necessarily enter the full cycle of addiction. What they do though is stay in the withdrawal phase. And the withdrawal phase is really difficult to live with. And this is the phase that the patients we have who've got stuck on opioids, who are not getting good pain relief and are very difficult to taper, this is the stage at which they're stuck. And so what you see is the drug opposite effects. They just feel miserable. They have stress-like symptoms, and they have decrease in sensitivity to natural rewards. So I'm going to finish there. And I was asked to leave this slide up so that we can go to closing remarks and questions.
Thanks so much. Thanks, Dr. Valentine and Dr. Kolodny, and thanks to all of our attendees. I know we're running close to the end of time, but we have some questions. First, I just want to mention there's a poll that's launching on your screen right now. We appreciate any feedback. Also, there's information on the screen on how to access the credits. You can also find that information in the chat. You'll be receiving an email in about 24 hours that'll have a recording of this presentation, slides, as well as information on how to claim your credits. But to our presenters, you know what, I'll go first with, you both spoke about the need for, identifying addiction and looking at ways for treatment and recovery. So I'll go to one of our first questions. Can you talk just a little bit on how long it takes for the brain to recover from the dependency and addiction? And also, do you feel that safe injection sites play a useful role in harm reduction? So
Sure.
that's 2 questions for both of
So
you.
I'll cover them both. So it takes about 6 months after patients come completely off of opioids for them to really get over the physiological dependence. And there are certainly effects of that opioid exposure that may remain for many years later. But when you take somebody off of opioids, if they've been on them for a while, there are the acute withdrawal symptoms. And if you can taper someone slowly, you can minimize those acute withdrawal symptoms. But once they come completely off, they're up to 6 months of fatigue, leg kicks in the middle of the night, irritability, depression. And because a patient, even a patient who always took their medicine exactly as prescribed, well, because they feel awful and they know in the back of their mind that, all they'd have to do to feel better again would be to take 1 pill, they can also start to have cravings, which really shows us that we don't have this bright line between physical dependence, which was said to be totally benign, and opioid use disorder, which was falsely said to be so rare. With regard to safe injection sites, we don't have good evidence on them yet. And I think it's hard to evaluate them because you'd have to really have sort of consistent practices and standards in these sites. I believe that in communities where there are large numbers of homeless injection drug users, it's a very sensible intervention that could prevent overdose deaths, and if administered properly get people linked to treatment. I don't think that safe consumption sites make sense in suburban or rural communities because I don't believe people are going to commute into town multiple times a day to inject an opioid if they have a home where they could inject. I think they'd sit empty, would be my prediction. But I think we should be doing this in the right places and studying it to see how well it really works and what are the right ways to do it.
Thanks, Dr. Kolodny. And Dr. Valentine, we have a question from a pharmacist. You mentioned that the CDC mentioned that misapplication of the guidelines included pharmacist and insurance limits. And this person asked their interpretation that this is a negative outcome of the guidelines, but in practice feel it's beneficial. Can you describe more or give some insight on that?
Well, it's both, isn't it? I mean, it's a negative outcome if someone's inappropriately taken off opioids too quickly, or for example, they're already on opioids and the pharmacy won't supply it because, I mean, we just had difficulty with certain opioids in our pharmacy, that some of them are available and some are not, and that produces a lot of problems. It's a part of the responsibility of pharmacists to actually make sure that they're not providing the drug, supplying the drug when it's inappropriate. So it's part of their role is to make sure they're not giving the drug to people who haven't had it prescribed or haven't got a bona fide prescription. And in that sense, that's a good effect of pharmacies actually restricting the providing the opiates, but there are also bad effects. I mean, that's I think that was recognized with the CDC guideline. There are a lot of very good effects of that, but there are also some unfortunate outcomes.
Okay, and just to follow up on that, you know, both of you mentioned if there's high dose patients, you know, trying to reduce at a slow rate the amount of opioids. So how do you support patients who are going through this withdrawal period to help with those symptoms? And how would you work with a care team to achieve what you've spoken about today?
I think Dr. Ballantyne would be best for answering that.
Yeah, I mean, in pain practice and in most primary care practice, when we're tapering opioids, we're trying not to have any withdrawal symptoms. We don't want to taper so quickly or not provide any alternative that you get withdrawal symptoms. One of the useful tools, very useful tools we have now is buprenorphine. And, you know, buprenorphine, in the way it used to be used was, you know, you would allow someone to go into withdrawal and then you would start them on the buprenorphine treatment. We don't do that as much with pain patients who are stuck on opiates. What we do with pain patients is start them on very low doses of buprenorphine and gradually reduce their full mu agonist or the normal opioid, and then gradually increase the dose of the buprenorphine so that in that way we avoid withdrawal symptoms. There is symptomatic relief for withdrawal symptoms, but generally we try to taper without producing withdrawal symptoms.
All right, thanks. I know we're coming to the end of our time, but I did just want to leave you with an opportunity to share one last thought with our attendees. So, Dr. Ballantyne, I'll start with you.
Well, I would say that the most important thing that we've learned, and certainly the message from the new guidelines, the 2022 guideline and the VA guideline, that CDC and VA guidelines, is that we need to treat the population of patients who've never received opioids as different from the population that are already on opioids. And those that have never received opioids, think very carefully about whether it's, you know, a good idea to start. We would generally recommend not starting opioids, particularly for young people. And the ones that are already on, just remember they're dependent and they need very careful care. And a lot of the principles of addiction treatment, even if you haven't diagnosed an addiction, they still need to be treated similarly.
Thank you. And Dr. Kolodny, one final thought for our attendees.
I just for the medical community, for individuals who are taking this, for the prescribers who have taken this webinar, there's a lot we can do to help address the opioid crisis. We can prescribe more cautiously so that we don't create new cases of opioid use disorder in our patients, or indirectly create opioid use disorder by stocking medicine chests with opioids. For many conditions where we currently prescribe opioids, not only can we prescribe fewer opioids, but in many cases, we don't have to prescribe an opioid. For example, we can often prescribe an NSAID. For those of you who may do primary care work, who are in a setting where it is possible to treat opioid use disorder, this got much easier now that you no longer need a federal waiver in order to prescribe buprenorphine. And so I would encourage many of you who might have thought about treating opioid use disorder to really begin treating these patients. You'll find it's very rewarding work. Patients do get better with treatment.
All right. Thank you both so much for being with us today and sharing this important information. I know we had a lot of confusion within our field, and so many people just, that we've interacted with when the headlines came out about the new CDC guidelines, as you pointed out, Dr. Ballantyne. So, I think this was just such an important conversation. And to your point, Dr. Kolodny, I think that we all have a role, whether it's as a prescriber or here, in the community, or as a person who is impacted themselves or their family member. So, or, in our prevention and treatment and recovery field. So, I want to thank you both again for being with us today, and the work that Physicians for Responsible Opioid Prescribing does in educating. So thank you. And thank you again for all of our attendees. I know we went over a little bit of time. I do just want to mention again, there's information on the screen on how to obtain your continuing education credit. You'll also be receiving an email with those instructions. So anything that you may need should be on that website. I appreciate again all of you being with us. I hope you can join us for our April webinar looking at the collateral impact of opioid misuse. So thank you again. Have a good day, everyone. Be well.
Thank you.
Thank you.
Thanks.